So I welcome all of you to this Cynodent conference, and it's very initiative, and I would like to thank Cynodent also for making me a part of it. So the topic which I have to present and I would be presenting with you all is introduction and classification for removable partial denture. So in this PPT, I would be basically dealing with and explaining you what is removable partial denture, how it is classified, and basic principles for designing. How do we actually design it? So before I would begin, I would like to say that classification is a very important part. Because suppose we have to imagine, like I want to convey my message to the students or to the technician. How would I say that this is, I want them to imagine something like that. What I imagine, the other person is imagining the same. So for that, classification is very important. Okay, so now I would proceed with my presentation and I hope you have a good session. So before I would, be giving an introduction and explaining you about the classification, one thing I would like to introduce and tell to all my students is like whenever the patient comes to the clinic, when we do diagnosis, we should always do a good treatment plan. And treatment plan and treatment should be such that we should, not do something which will harm the patient. Either, we correct whatever I would not say the word correct, rather treat with whatever the cause is. Or, if you just cannot perform, we should, consult it to hire people or, leave it like that. We should never do something, if patient has come with state, you should never worsen the state. Iatrogenic, which we say, you should not do something which will increase or cause harm to the patient or worsen from what condition he has come to the clinic. So it is that statement I want to explain. So according to Muller D. Van Dictum, the perpetual preservation, that means we have to preserve remaining of what is remaining is more important than the meticulous replacement of what is lost. So before we are replacing the missing teeth, see basically removable partial denture. When we are talking about removable partial denture, the thing is that few teeth are present. Even if one teeth is missing, that is partial denture. So the state of dentulous. Edentulous means none of the teeth are present. Dentulous means one, two, whatever teeth is present. And removable partial means some amount of teeth is present and the other we have the tissue. So whatever if the teeth is lost, so more important than replacing the teeth which has been lost or the missing teeth, we should be very kind enough and think of preserving of what is present. So in that RPD, designing plays a very important role where we should know where the abutment, where the rest, we should place such because all this will be placed on the abutment tooth. Now, what is abutment tooth? Whatever edentulous space, the tooth next to that is the abutment tooth. So most of the things are placed on that. Whatever your rest seat, the designing when we give to major connector. So that has been kept in mind. So just because you have to replace that tooth doesn't mean you'll cause any harm to the abutment tooth or the teeth which is present. Okay, because if patient has come with a very healthy tooth, we in the abutment we are giving more forces, and it leads to another set of problems. Then we are wrong there. So it's very important to understand classification and how we go on with treatment planning, designing of removable partial denture. Conservation of residual alveolar bone should be a prime priority, as the success of any treatment is highly influenced by the amount of bone. Obviously, if bone is there, that is the support. The amount of bone present, that is giving you the basic major support for maintaining, for wherever where will you place it? If there's so much of resorption, you cannot place anything. It's very difficult. Any prosthesis should be provided as part of overall management that meets the basic objectives of prosthodontic treatment. So what? What we have to be concerned with while designing removable partial dentures, elimination of oral disease to the greatest extent possible, preservation of health and relationship of the teeth and health of oral and paraoral structures, which will enhance the removable partial denture design, and restoration of oral functions that are comfortable, are aesthetically pleasing, and do not interfere with the patient's speech. Now, before we proceed to the classification and everything, I would like to say what is definition. So, definition is a removable denture that replaces some teeth in a partially edentulous arch. The removable partial denture can be readily inserted and removed from mouth by the patient. So anything patient himself can remove and place it, that is removable. Fix, you cannot remove. So here removable patient partial denture, this is the proper definition which you should write in GPT 9. See now, in India that we give is totally, we can say that is not cast partial denture. What we are giving is TPD. Okay. So, what is cast partial denture? It is something similar to removable partial denture, but it consists majorly of metal parts, which are, nickel, chromium, cobalt, chromium. That is made to make it. But it is more expensive than removable partial denture. So it is defined as a removable partial denture which consists of cast metal framework that contains artificial teeth in an acrylic resin. As compared to conventional acrylic denture, cast partial denture is stronger, more durable and retentive. But it is expensive. The problem is that it's very expensive. And generally with socio-economic people, where such cases are there, people are not ready to pay that much. Like CPD costs you somewhere around 6,000, 7,000. Starts from there. So that cases we are giving removable partial denture, but we should plan it very well. If we plan it very well and we are giving with acrylic also, it would go a long way. Okay. So first, so now we are doing with classification of partially edentulous arches. Now, one thing is there that why do we require classification? Why? We are saying we are doing this classification, that classification. Before anything, you should know why you require classification. It should permit immediate visualization. Suppose I am telling you this is class 1. Suppose I'm giving example. Just listen. Central incisor is missing, and I am saying that it is class 1. So as I see class 1, I see that central incisor is missing. You should imagine, okay, it is class 1 because central incisor is missing. That means suppose, you're doing the diagnosis of the patient and you're coming to me and saying that, ma'am, it is class 1. So immediately I imagine, okay, it will be like that. So as you say class 1, class 2, so certain amount of this thing is given, okay, two teeth is present, three teeth are present, which part is present, whose classification is, so that we visualize the same. That means if this thing is orange, you say orange. Even if I'm sitting anywhere, I know that is orange. Similar, it goes with classification. If I'm saying it is class 1, everyone who has read or who knows get to visualize, okay, it is class 1. Then differentiate between potential tooth-borne and extension-based partial denture, whether it is tooth-supported and or whether it is tissue-supported. Tissue-supported when there are no posterior teeth, and tooth-supported you have support anterior and posteriorly tooth are there. So you should know because when it is tissue-supported, I'll just show you all the forces are going on the tissue. So that is something very different, completely different. Okay, and when it is tooth, so we get to know, okay, tooth is there, so we can design this way, that way. So that also immediately we begin to think. To get a general idea of the type of design, to know the general location of the teeth being replaced, so we know, okay, if it is class 4 anteriorly, if it is class 2, this I am referring to Kennedy's, which I will tell you what it is, and it should be universally accepted. Obviously, universally accepted means even I'm sitting here and saying class 1 Kennedy. In Rome also it is class 1 Kennedy. In US also it is class 1 Kennedy. And in Australia also it's class one Kennedy. It's orange or black color or yellow color. How color is like that? If I say yellow, if there are eight people anywhere, they know what yellow is. It's like that. So why do we need? Without classification, also, why so much of classification? Why, so much of things to learn? So it's like this. Classification itself facilitates case history recording and exchange of views between practitioners. I'm stuck somewhere. Someone very senior to me, he knows much better. He's sitting somewhere, nowadays, how telecommunication, how Wi-Fi, how internet, they're just so fast. So if I want to, do immediate case, and now so much of competition, like no one would like to leave any patient any time. So if I want to, very some of my very senior doctors I want to ask, or say a lab person wants to ask कि मैडम ये क्लास वन जो है यहाँ पे ये देना है or whatever, or suppose some other dentist, I have seen its case. He has gone to some other country, leave about country, suppose in India, only different state. So, okay, a patient had come to you, this name, it's class two Kennedys. Okay, so class two, I begin by, okay, that patient, okay, so go on. So what he's saying, I'm able to visualize, or I want to take consent with other practitioner. I tell him, sir, there's a class three case. Okay, so first thing in mind, what do you think, class three? Before giving, okay, it is tooth supported. Okay, then imagination goes that way. So exchange of views, like if I'm, going to market, I want to buy a yellow thing, yellow t-shirt. I call my mom and I say, see, should I buy yellow or blue? She's like yellow, so we know what it is. That's what I want to tell you students how it goes about. Provide general acceptance of particular system. So we have to say because classification is not like blue orange. What I'm saying that is universal color. There's Kennedys in this Bummers. There's another. Suppose in some countries they are not practicing Kennedy at all, or we have a software which is just on Bummers. So how we go about it? That time, okay, this classification it is like that. It should give clues to the treatment. Also, so I know, okay, if class three, it is tooth supported, then I can use the abutment. If it is class one, it is tissue. So even if I use the abutment, I have to give mesial rest, distal rest. It's totally about how I imagine that ways. Facilitates the visualization. Main thing is obviously visualization. We think the same thing. So for that, it is very important. See, students, these are the classifications, very important. You should know at least the name, but Kennedy's is overall accepted. Mostly we follow Kennedy's classification, but there are few cases if Kennedy's, this cannot be done, that cannot be done, then we go with Q-birds or others. But universally accepted in all over India, most colleges, Kennedy's, other places also, it's the same. So it was given in 23, but when you're writing your answers, and for your neat purpose also, they might ask you any classification with you. So if you want, you can just note it down. It's important from this point of view. So you can just note down. Now see, I will be dealing basically with Kennedy's classification because in your answers, if you ever getting to write, you write. Suppose you get a question that what is removable partial denture or define removable partial denture, and write about the classification system. Basically, we write about Kennedy's. So there you go, and you write about Kennedy's classification. So class one is I'll just show you in pictures also. So now which I'll be doing it will be of Kennedy's. Bilateral. Can you see the pink color? That is the edentulous. Bilateral means both sides. Bilateral edentulous areas located posterior to the natural teeth. See, these are the teeth you can see, and these are the bilateral areas which are located posterior to it. So easy. So this is the diagram you are supposed, and it is compulsory to draw. Then we have class 2. So that was unilateral. That was bilateral. Unilateral on one side. Okay. So a unilateral edentulous area located posterior to the remaining natural teeth. All these teeth are there, and this is the unilateral edentulous space. So why classification is important when I'm saying class 2? I don't have the picture. I'm speaking to someone else. Or today when you learn this, visualize, you get to know, okay, this is class 2. This is universal class 2. Okay, but the picture, suppose even if we have central lateral from canine onwards, that will be also counted as unilateral. Class 3, we have tooth anteriorly and posteriorly, both. So that is class 3 Kennedy's classification. Unilateral edentulous area with natural teeth remaining both anterior and posterior to it. And then what is class 4? See, 3, it was, anterior, posterior, but posteriorly. And here it is midline. Whenever a single but bilateral edentulous area crosses the midline. Now, this is single but bilateral. Located anterior to the remaining natural. See the difference. In class 3, what it is? Remaining both anterior and posterior to it. And here teeth are in class 2, teeth are whatever the remaining natural teeth, they are located posterior. The space is posterior to it. And in class 4, it is anterior to it. So this is the diagram. Whenever if you're given classification, I would request all the students you get full marks. You draw this diagram, you write this much, you'll get full marks. So I'm just showing this. Suppose you get it this design. Now why it is class 2 modification 1? Class 2 because see, first I will just show you Applegate's rule, but before this I'm showing class 2 because you have unilateral. We learn unilateral edentulous. You cannot say class 3 because first we go with the most posterior spacing. Okay, whatever the posterior edentulous space is there. So this is class 2 mod 1 because one more. What is modification? The number of extra edentulous spaces which are added other than classification. See, this is class 3. Okay, mod 2. Because this anterior posteriorly you will consider it 3 and 2 more spaces. This you will get to know when you understand the Applegate rule. See, advantages of classification is obviously it permits immediate visualization and permits a logical approach. Logical because it will be more faster if we visualize faster. So this is more important before you give anything. Applegate's rule always goes with Kennedy's classification. Rule 1, classification should follow rather than precede any extraction that might alter the odds. So always, you after extraction of the teeth, that time you decide what is the original classification. So it should follow rather than precede any extraction of teeth. So before extraction, you cannot do this. After the patient is extracted, everything is done and come, that time you decide, or even if your treatment plan, okay, this will be removed, so this will be class 2. So classification should always follow rather than precede any extraction. Only after extraction you can give that those classification. If a third molar is missing, and also see in the rule one thing is there, so the posterior most space we consider it first. If a third molar is missing and not to be replaced, it is not considered in the classification. Okay, if it is missing and we are not replacing it, so we cannot, consider that okay, that will be considered. We have to imagine whatever is there, you have to deal with that. If a third molar is present, then it is to be used as an abutment. It is considered in the class. If we are using the third molar and it is abutment, then okay, this will be class 3. Okay, we will not imagine, oh, we'll extract them. That's why the classification should follow extraction rather than preceding. If it is there, it is there. If it is extracted, then it becomes class 2. If a second molar is missing and is not to be replaced, it is not considered. Okay. If we are not replacing, why we'll consider? We'll consider is a same with molar. If it is missing and we are not replacing, it's not considered. The most posterior edentulous area always determines. See, this is very important. Suppose just in this picture you imagine. So what is this? Most posterior. Okay, this is the most posterior. So this will be class 2 and 2 modifications are the extra spaces. So just see on the left, my left side. My left side, that space is class 2. Two more spaces are missing. These are modification. So class 2, mod 2. Class 2 because my left space side, my left side once edentulous space is there. My right side, those two are modifications. Edentulous areas other than those determining the classification are referred to as modifications and are designated by their number. So I will just ask any student, can anyone tell me what is this? Whether this is class 1, 2, what modification is this? Okay, so see, I'll explain you. On my right hand side, that is, it will be your left hand side if you're seeing. Okay, that is, I can say where there's totally edentulous space, where there's no tooth. So we studied that always the posterior will be considered. Okay, so this is classification 2, class 2, because unilateral edentulous space. And then we have edentulous area other than those determining the classification. So that we are leaving. That one we have considered for classification. Apart from there, how many we have? We have these anteriorly missing. Then after canine, we have another missing. Okay, again after molar, we have missing. So there are three spaces. So this, which currently you are seeing in slide, that is class 2, mod 3. 2 is the space and then 3 spaces other than edentulous is available. So this is how the classification goes. Okay. First thing, if you remember, I'll just go back. I'll just go back to this because it is important. See, first being space where you see that, you know why three? First you have to say anteriorly, posteriorly one, that is class 3. And other than the edentulous space which you are counting for classification, we have two more space. So class 3 mod 2. Let's go for the tissue. This is to tissue supported. So you see the most posterior space. This most posterior space, you cannot tell this. You get confused that this is class 3. No. Class 2 because the posterior most is considered. So this is class 2 because unilateral edentulous space. Okay, that is class 2. Then we have one more extra space other than which is then classification. That is modification 1. So that ways, that was all about classification. So the Kennedys always go with Applegate. I hope you have all understood. If there's any problem, you can always ask. Now I would go for indications for removable partial denture. Now in long span edentulous area, what happened? You cannot give fixed partial dentures because there'll be cantilever, which you will, if you are reading FPD, you'll get to know as soon as you reach your subject. And that will obviously lead to failure. So here we give long span edentulous area. Then when no abutment tooth posterior to the edentulous space is there, where will you get the support? The second picture see. There is no support. How will you give fix? You cannot give a flying FPD or just cantilever FPD. So you give RPD in such cases. If periodontal support is very less, not possible. What will happen is it's very difficult. It will not take up only because it needs a good support. If periodontal support is very less, how will you take up the apartment for giving rests or maxillary major or minor connector? It is not possible. In cases with cross-arch stabilization, that means see, wherever fulcrum load is FF, can you see where it is written FF? That is the fulcrum line. Okay. So wherever it is passing cross arch, means when the RPT is crossing both, it will stabilize both. But how this stabilize cross arch? Okay, cross arch is important. Between two arches, that is cross arch. Hmm. Excessive bone loss is there. There also you cannot give FPD because whatever bone is there, more will be the bone loss. Whenever, because the bone has to be there. If we are giving, FPD and all, the bone quality should be given. That is totally different. The Siebert's classification is there. Then we have the Mish classification. So that is totally a different topic. Okay, so when excessive bone loss is there, you cannot give. So in that case, RPD is indicated. Physical or emotional problems when it is exhibited by patient or aesthetic is primary concern. There also, you generally don't give other things, you give removable partial denture. Patient is very emotional. Some patient when you'll see, they will come and they are like, हमें fix नहीं चाहिए. We don't want something to be done in a tooth, something like that. We want removable. In that cases, you have to give removable. Now see, when a load is applied to a fixed partial denture, you cannot give, no, that the gray, dark gray lines you're seeing. So that is, we are telling that how, if there's a long space or means there's no support in the other end, you cannot give FPD. Harmful forces will be there and it will be acting on the abutment too. So it's not possible only. So you have to give the RPD. Now, here I want to show one thing. When you can do a good, before telling in detail anything, everything, done that, good RPD can only be done when you plan, when you design, and then you construct. Planning and designing are the very essential part. So when I say plan and design, planning, you see you see this OPG, the figure one OPG. Okay, then you see think that what classification it is. So the upper one is obviously bilateral, Kennedy's one, the lower is Kennedy's two. There's no modification. So now you say, okay, in one or two it is two tissue supported it is. So you have to take a different set of impression that is in which functional and anatomic both is there. So that is pick up impression. So from here you begin to visualize and you think. So that was plan. So many planning. You take a paper, you write, okay, class one is there. So in this, we make this impression. What impression material is used to, make impression if tissue supported is there. Then where you can give the class, okay, or whether you have to do steps which are similar to complete denture. Then you design. After you get to know, okay, this is this. You make a cast, you make impression. Okay, then you design. So in designing, we have color coding also, which I'll be showing you. And then you carry out your lab procedure. Then you get a good RPD. It's not just you sit, okay, make impression. Ma'am, wherever teeth is missing, we are placing the teeth. And then you do it. No. So it is always plan, design, and construct. Okay. So see, so design, I mean, when you design before you plan first, so you make an X-ray, you make a diagnostic card, you articulate. You know, now articulator is so important. Most of us don't use an RPD. You see in colleges, I've seen students even after you will saying, but students, you just try, you see two cases, you'll be more than happy. Even when I was, initial stage, I used to think that, okay, it's a workload. No. But when I, made impressions, then I, articulated it, and I could visualize that this articulator is the patient himself. So do not underestimate removable partial denture and thinking we do not need to articulate. We need to articulate. Okay. So you do the articulation, you see what are the supra-erupted tooth doing, whether it is falling in the missing place, and see how wonderfully designing is done. That whether where spaces have to be given, where your rests will be placed. It is all like that. So if you go the steps, first you go diagnosis and treatment planning. So that is done with X-ray. Then you make a cast. Surveying is totally a different job. We have to survey because surveying, guide plane ki from where, kahan se aap, uh, you will place the denture and from where you remove. There has to be a one path so that you'll get to know. Then you design. So when you design, you're designing, you're seeing mouth preparation. What happens, sometimes tilted is there, tilted tooth is there. How will you make the abutment? It will tilt more and you'll cause harm. I told in the starting, you cannot cause any harm. Okay, so that time we do the mouth preparation. That is, we will, do sort of enameloplasty, something like that. Then, if any FPDs have to be done for RPD abutment, then we make the final framework. Sorry. Then we do two casts. Okay, make two casts. Then again, surveying is done, designing is done. Then John Lation is also recorded. Then we do the wax up. We have to do the wax up because we have to show the patient also this is the way. Then we do the casting. Then it is framework trial is done. Then altered cast impression. Again, after we getting altered cast, this is a totally different technique. You do the jaw lation. After you do the jaw lation, you do the trying. Then you do processing and then this is such a big step. What you people do just make impression, place wax, place teeth and over. It's not done like that. Theory wise also, when they are doing CPD planning, RPD planning, it has to be done like that. These are the steps which are followed. Now, biomechanics, when I'm going with biomechanics, I mean how it is working, what a removable partial denture, how important it is, and how it is working. So we have the force, liver and fulcrum. Why this is important? Because see, force we always have to see how much force is acting. If it is anterior teeth or posterior, more biting force is there. Liver is the, basic mechanics which we'll follow is class one, 2, 3. So we have to decide which liver and so designing comes basically from the bio. See, bio is whatever the biological state is, mechanics is how through mechanics we can cause less trauma or no trauma at all to the remaining structures. We should not do something that will cause more force on the abutment tooth and cause resorption of bone and all. Okay. And fulcrum is in all three planes. So on these three things, the entire biomechanics of RPD is being done. Before that, see just to see the diagrams, forces acting on tooth and tissues. Okay. So see, these are the forces which are acting on the tooth and tissues. Suppose this is tooth supported. All this is tooth supported. So nothing, no problem is there. You can see the middle tissue. Okay, the ZZ line. All forces are taken up by the abutment tooth. There's no trauma, nothing to the tissue. Same with the other diagram. Now see the difference. When it is tooth tissue, see, I'll show you again. Tooth supported. All the forces directly acting on the tooth, very less on the tissues. But here, tooth tissue. So your everything, the tissue is taking up. So when you can see, we have to think where we'll give the rest. Now, in such cases, biomechanics, how it is important. If suppose for the first diagram you see the first figure which you can see, so if tissue, forces are acting on tissues, so what will we do if we place a rest, rest we place so that it acts as a stop in removable partial denture. See the gray arrow here. So this is your rest. Okay. So if what happens if we are placing a rest on the distal side that it is very close to tissue, so it will cause rotation and it might cause the tilting of the abutment. So that is will be very difficult. Okay, because then it is causing more this on the tissue surface. Now, if we are placing the mesial rest, okay, we are placing it on the mesial surface. So we have to see whether it is close to tissue or not. So there should be no rotation. So whenever there is rotation, it will be more on the prosthesis. So that is okay. But abutment tooth, that forces should not be there. That means forces should not be such that it causes tilting of the abutment tooth. I just want to show through the diagram. See, if it is tooth supported, so when you are visualizing it is tooth supported, you get to know it's easy. Why? Because the abutment tooths are there and those tooths are very healthy. And since we have tooth support also, it will directly fall on the tooth and much harm cannot be done to the tissues. So that is one thing. But if you're giving tooth tissue, you have to be very this how you will make impression. You have to do border molding. You have to do, dual impression technique. Why dual impression? Because you have to record in functional and anatomic, both. Then only you'll get a good denture. So While designing, other thing we have to know is the fulcrum line, because fulcrum line is the thing along which all the prosthetic parts are placed. Okay, all the parts of RPDs are placed. Basically, if you go with parts of RPD, those are major connector, minor connector, rest. Okay, abutment is never a part of RPD. It is tooth, so you cannot include in the tooth. So denture base, so rest, major connector, minor connector, retainer, rest. Okay, direct retainer, indirect retainer. Direct retainer is the class. So I'm just telling you the part. I will explain you more. If you have any doubt, you can ask. Okay, but how we have to place these specific parts depends on the fulcrum line. Along that, the entire prosthesis is rotating. You have seen the seesaw. If it is like this seesaw, it's rotating. So suppose this is the I'll just show this. This is the fulcrum line. Suppose my face is the center and this is the seesaw. It's on rotating. So this is the fulcrum line. This is the fulcrum on which it is rotating. So any line passing through is the fulcrum line. Similar goes with this. So horizontal fulcrum line passing between two principal abutment teeth. See, wherever it is a line passing through the posterior most abutment tooth. After drawing that, only he will decide where to add rest, direct retainer, indirect retainer, major connector, minor connector. Everything depends on this. Okay, because that will control the rotational motion of denture towards or away from the supporting ridge. That is important. So, what is fulcrum line? In the removable partial denture, the horizontal fulcrum line is what? A line. It is imaginary line. It is obviously not there. We are imagining because then we have to design the RPD. So it is an imaginary line passing between two principal abutment teeth which controls rotational motion of denture towards or away from the supporting ridge. And moreover, this is the posterior most abutment. You see in all the diagrams, that is the posterior most abutment. Now, existing of fulcrum lines and the axis of rotation, this is also important. When the fulcrum line is horizontal, okay, see in the picture extending through rests on the principal, the axis of rotation lies in sagittal plane. So we get to know this is the sagittal plane. Three such fulcrum line and axis of rotation exists when we are doing RPD. This is if very not important from BDS point of view, but if you are going for your PG examination, it is important. For NEET MDS, it is important. Okay, but if you're finally a BDS student, you want to write, you just understand this. What is fulcrum line? Okay. And second, when fulcrum line is sagittal, see the line you can see, that is the fulcrum line. Okay, when the fulcrum line is sagittal extending to rest and along the crest of edentulous ridge, on one side the axis of rotation is in vertical plane. And when it is near the midline, it is in horizontal plane. But this, you understand this. All these lines which are drawn from cast 1, 2, 3, 4, 5, 6, these are the fulcrum lines. See the sixth cast, two fulcrum lines can be there. If two are there, one is from premolar canine. So first you have to think which abutment will be stronger, premolar or canine. Obviously premolar is stronger, so that we will take. Okay, so that has to be kept in mind. Now, what are the principles when basic principle of designing? Strain in supporting tissue, stress on teeth, they should not exceed the level of physiological tolerance. There's always tolerance. Suppose 80 is the tolerance, then both these two can only be 40, 30. It cannot be more than that. And what is the movement and the functional load? Okay, that is important. Basically, your RPD, if they ask you what they work on these six principles. Simple mechanics, lever, wedge, inclined plane, okay, pulley, wheel, and axle and screw. On these, so these are the basic principles on which they work. Now, mechanical principles applicable. Lever principle. See, now this one fat cat is there. Okay, so it's like a seesaw. So two cats. So similarly with tooth. Okay, that if two abutments are there and they are very healthy, you can use that. And if one is there, if molar is there, it is more healthy, you can use that. So lever principle, first though you have to imagine whether it is one, two, or three. Okay, which I will just discuss it further. Then inclined plane is very important because whenever inclined plane is there, that means suppose you are, giving a class retainer or something like that, and they are just having a friction, so they will remove, they'll pull against each other, which you don't have to do. So wherever you have to see if inclined plane is there, then how you will apply force so that they are not there. That is important. Snowshoe effect, see, it's simple. Like when you are, when you go to the mountains and you do skating, so how more the surface area, you cannot use your normal shoes. They won't be helpful in skating. So more the surface area. That's why it's saying snowshoe effect. Okay, so more the surface area, more better, the RPD will be like more, see, it will work for a longer time. It's like that. So when you see how much the surface area, larger the surface area, it will take up more of forces. So that's why if it's in maxilla, so if you're doing in the molar, if it is tooth supported, then well and good enough. Support is only good. But if it is edentulous, if it is in maxilla, see, in maxillary, the forces it can bear more because the surface area is more. That's not the case with mandible. So in mandible, to change that, if we are giving swing lock appliance or something else, that we have to see. Another is L-beam effect. L-beam is nothing, which you see pillars. So if the pillars are just, you know, straight, any force, so it can do this, that. But if the pillars are such like this, so like this, if force is acting here, where I'm giving this L beam effect. So that time there won't be any damage to the prosthesis. They will take up the forces. If it's acting directly, it's a problem. If we're giving L beam, that means you can see in this diagram, half is on the, suppose on the lingual surface, you see. Half is on soft tissue and half is gone just, to the gingival part of the tooth. So it is L. L shape is important. Any forces there will not lead any fracture. If direct is there, that's a problem. See class 1 liver, how it is there. Fulcrum classification is based on location of fulcrum. Okay, I just wanted to point my cursor. Class 1, the fulcrum will be on the middle. Effort and resistance. It's very good. Okay. Effort and resistance is there. Class 2, effort is away from resistance, from fulcrum line. See wheelbarrow how it is. It is same like, so what happened, the whatever effort is like, it should be such that whatever prosthesis you are placing, the effort arm should be longer. Like if you are, making the effort, so it will not come out faster. So that way you have to design your prosthesis. And class 3, see, effort is closer to fulcrum and resistance is far apart. Okay. So what I wanted to say according to this is the classification is based on location of fulcrum and direction of effort. In dental terms, E can represent the force of occlusion. So here E is all force of occlusion or gravity. F can be tooth surface. F, you can imagine F to be tooth surface. So, such as an occlusal rest, because obviously rest will be placed on occlusal surface of tooth. It's generally placed that way. And R is the resistance provided by direct retainer or a guide plane surface. So where we have to see where force, where it is the tooth, how much resistance it will take. And as said, E is the effort. So if it's like if a lot of effort is given, that time you cannot remove the prosthesis. It has to be such. Okay, because then that will cause, introduce more force and cause lot of problem. Okay, so it is like that. So you have to keep in mind where fulcrum is, where it is rotating, whether you have to keep it away. Now suppose fishing you are doing, I'll just give you an example. See in the third class, if the effort arm is longer, you require less effort. You'll just be able to, pick, or I'll just give example of paint box. If this is a paint box and this, you go and open from this very, small stick, it'll take a lot of effort on your fingers to open. So you take a long stick and open. So with less effort, it is removed. So that has to be the prosthesis. Okay. So that's why you cannot place it very near. Obviously, whatever prosthesis, it has to have a longer effort arm. Okay, from a distance. It should not be any time towards the fulcrum. It should be away from the fulcrum so that the dentures are not dislodged easily. It has to be like, and while removing, with less effort, you are able to remove. Okay, that should be the concept. So because displacement will be less. See, with the case of main box, if you're from removing, you can't. So it should be such that from near, if you try, you can't. The longer the effort, a lot of effort you require, that time it doesn't come out. It's same with the paint box. Effort arm the longer. With little effort, it will be able to remove. Okay. So that way the parts have to be placed, whether it is rest, whether it is, major connector, whether it is minor connector. See here, mechanical advantage effort arm by resistance is 2. So actual it is 2. So effort here we told, load is, the tooth. This is the fulcrum line. So whatever effort, that means whatever your direct retainer and all has to be away from the fulcrum. That way it becomes easy. This is your color coding. For metal components, clasp, connectors, lattice, rests, we give a brown color. And red is for guide planes, rest seats, dimpling. And for blue, we have the acrylic component. So this is very important. This is color coding is universal in removable partial denture. If I say give red seat, you have to give red. You cannot, if you are sending it to me, I'm a lab person. I've not studied what is red seed, what other things are. I see red, and I imagine this is red seed because we have to connect with them also. So there's a quick glance, just the various parts. So for that, see, I'm telling you, saddle, main component distributes low teeth, mastication, aesthetics, direct retainers are also known as clasps. See this diagram, you can just click. So See, A is the major connector. That is this big whole framework which is connecting from one arch to the other, one part of the arch to the other. That is the major connector. Okay, so B, these small parts on occlusal surface or indirect retainer, those are very important because they, all the forces are, to the vertical. Vertical forces are always good. They don't cause any harm. So they are acting just on the tooth and they are causing all the loop to act vertically. Here, their oblique forces, they will damage the prosthesis and the abutment tooth also. So see, B is rest. C is direct retainer is the clasp. Why we give clasp for so that the whatever your prosthesis, whatever the denture is, they are stable. Okay, we need support. We need the tooth abutment support to place the removable partial denture. Then we have the minor connector. Okay. Minor connector is like, which will join the rest class to the major connector. E is the guide plane. This is the guide plane through which the processes will be placed and removed. There has to be only one guide. Only one, one guide. We cannot be many or it will be very difficult. Path of insertion and removal has to be one. And then we have the indirect retainer. Indirect retainer, they compensate for other kind of forces. You see in the table one also the picture it's written. Direct retainers are for retention, bracing, reciprocation, support. The indirect retainers are there for unification, load distribution, rotation, and minor connector, stabilization, load transmission to abutments. The basic philosophy of the design should be stress equalization, physiologic basing, and broad stress distribution. Now, what is stress equalization? Whatever the clasp is, what material, whether the class, see, these all chapters are very different. I'm just giving you my agenda is to give you what it is and how you should design. Then you should study properly what are the clasps, with what materials they are made, whether they're active, whether they have to be passive. Those kind of things are important. Physiologic basing is amount of force Okay, and how much, see, whenever tooth is there, it has periodontal ligaments. So movement will be there. When it is tissue, lot of force is there and it causes resorption also. So all those has to be kept in mind. Kept in mind. Broad stress distribution is use a larger surface area. More the surface area, more the stress, less hampering to the abutment, and less the prosthesis is hampered because everything is distributed. Imagine you have a big, wherever you're jumping, or suppose a big table you have. You can keep so many things and everything distributed properly. With small, you keep so many things, the table will only try to fall. It's like that. More, use more surface area, so that the forces are distributed. These three we have. Stress equalization means whatever you are using, designing like direct retainer, major connector, clasps, and all. What material, whether they are active, passive, and how much force they can absorb. It's more important. Here, one thing, see, light gray, dark gray line, you can say. So, full extension of denture base permits a more favorable distribution, and the light shaded area depicts underextended denture base. The darker shading depicts a denture base that has been fully extended. So, we should make a fuller one. Never extend to half. If you're not extending fully, force distribution wouldn't be that good. That means what I want to show through diagram is light gray is wrong. Extend it to dark gray. You people just, little bit behind molar, first molar, you stop. No. Go till see the area where it is. Till the retromolar pad, before the retromolar pad, where it is. The dark gray is area, dark gray, wherever in my picture it is showing dark gray, it has to be extended and not to the light gray area. You cannot just little bit extend behind the molars and leave. You have to take the tissue surface. How much load? The tooth cannot take that much of load. Not possible. See, inclined plane is basically, when you're placing your wrist, it is important. So the enclosed angle formed by line drop down. See, I want to show this. I have been referring from Stewart. You can read the wonderful book. Okay, so the enclosed angle formed by line drop down the proximal surface. So the of the rest seat must be less than 90. If it is more than 90, it gives inclined plane effect and generally it tends to come out. An angle greater than 90 transmits destructive forces and creates an inclined plane effect. So we do not want that. I told you if it's an inclined plane effect, that means from both ends they are, pushing. So there's lot of stress from here also from there. That we have to prevent. If it is 90-degree, it is fine. It is more than, as it is more than 90, friction is created from here also, from here also. From tooth is there. So from here also the prosthesis parts are creating inclined plane. So from here also they are putting, see the red arrow. Best is see the picture. Second picture, A, figure 276A. When force is there, left side, right side, arrow is there, they both are trying to pulling each other, which we have to stop. So B, the latter phenomenon result in migration of the effector. So whatever the abutment is, it will result in migration of the abutment. So anytime we are placing this, it has to be less than 90 because then 90 or less than 90. Otherwise, inclined plane effect will be there and it will cause migration of the abutment. So always remember when you're reading your chapter of rest, more clarity will be there. Okay, but when you're placing rest, it has to be less than 90. Here, I just wanted to show what is the fulcrum line. See the line passing through the distal rest on the mandibular first premolar designates the primary rotational fulcrum. Application of an occlusal load will result in rotational displacement towards the underlying supporting tissue. Okay. Now 379 you see. Illustration of fulcrum established at the occlusal rest. So F is fulcrum, L is load. This is fulcrum, this is load. Prosthesis rotation around this fulcrum causes the extension base to be dislodged towards the underlying soft tissue. So to compensate this, see the diagram properly. Load is there, fulcrum is there, and this third arrow, F for fulcrum, L for load. So what happened when it is there? So we have to think that way is ki we have to shift the fulcrum. So now what we have done, we have shifted the fulcrum away. See, here what it is, fulcrum is in the center. Okay, but here, next picture, we have to think and take the fulcrum away. So illustration established at the retentive class terminus when the dislodging force acts on extension base. Rotation of the processes causes the extension base to be displaced away from the supporting tissues, while the anterior portion of the processes rotates in apical direction. So what happens? Rotation of removable partial denture may result in unwanted processes impingement into the soft tissues of the floor of the mouth. This rotation may be effectively countered by placing a rest on the opposite sides of the fulcrum from the extension base. So you see, this arrow, there's nothing. Now what here we have done, we have placed one more rest. So that is the planning and designing. We got to see in this how fulcrum is acting. So this obviously will rotate and cause impingement. But if here we place one more rest, okay, that is, and fulcrum also change. We place one more rest, then there will be no impingement. See in this diagram only. So very good. Oh, the fulcrum is here, whatever the load is here, everything is compensated. How A and B are so different. Okay. On the left side, you see if the fulcrum has been shifted. As soon as we place an extra rest. So now here, that is they are saying how here also figure A, B, you see, if there is no rest, then how the processes will tend to rotate. That is, it is shown. And when we have added indirect retention, okay, in C you see, in diagram C, indirect retention, then there will be no rotation of the processes because that is giving full support. Forces acting to dislodge RPD occur perpendicular to the occlusal plane. So these broken line, through this only they are acting. The red color broken line to effectively resist dislodgement, the path of processes ensure that should also be perpendicular to the occlusal plane. Means see these red arrows, large arrows, in this only removable and placement should be done only in this angle. You cannot move it left, right. It has to be in this. This is the principle. You do left, right, you are hurting the abutment. As I told in the first statement, we cannot do any damage. Patient is in good situation, but you're not utilizing abutment properly. Extra force is there. That is leading to failure of RPD and more and all causing damage to abutment. So this is the Prothera's cone theory, which you should go. And the deepest portion of an occlusal rest should be located near the center of the mesial or distal fossa. From this point, the rest sheet should rise gently towards the marginal ridge. This is the proper and perfect way of placing the rest. Deepest portion, okay, and it should rise towards the marginal ridge. So, how much the thickness is? Obviously, 1 to 1.5. See these rests, why they are important? Because these are the vertical stops. Vertical stop and they are forcing vertically down. Left, right, any force will cause loss of damage. When a cast restoration is planned, an appropriate rest should be. Now, what one thing is there, suppose you're giving an FPD. Suppose abutment is there, which is not that healthy in RPD, like it is tilted. Just giving an example that we have canine. We have first premolar and one first molar, and the second molar is mixing. So suppose the first premolar is bit tilted. So it is tilted, that pulp might be exposed, something like that. If it is tilted, then obviously when you're placing and removing RPT, it will be a lot of problem because the tilted portion will come in between. So in that cases, we do tooth preparation and then we are placing with FPD and then using it as abutment in RPD. So what we do in that case, the receipt will be made in the cast itself, the crown. So in that case, when wax pattern, when the we are giving it into the lab, then in wax pattern only that rest seat would be made. Okay. It is like that. In cast restoration is planned for an abutment, rest seat should be carved into the wax pattern. You cannot give it later or make yourself. So in the crown, whatever it is coming in the FPD, if like first premolar, In the crown structure only means what you're getting from lab, what prosthesis you're getting from lab, the crown, in that only the rest seat would be there. So in rest, you have to go into detail. The abutment surface to be contacted can be made parallel to the path of insertion. See, this is very important. Like I wanted to show in my diagram, whether you are giving incisional rest or cingulum rest. Cingulum rest is given in canines. Incisal is given in incisors. So incisal rest, you see rotation. The it is not to the closer to the rotational center. So if you have both options, go for cingulum rest. So that this is the basic of designing. That this way you have to follow. These are the minor connectors. You see the arrow in figure 2.2. Minor connectors include proximal plates, resin retaining element. So parts I have explained you. So this I'm just showing you more than two. In 2.3, you see rest contacts the surface of it to prevent movement of prosthesis towards the underlying oral tissues. Properly positioned rest maintain the correct placement of the removable partial denture and prevent damage to hard and soft tissue. So figure 2.3 is showing you the rest, how proper they are placed. Okay. Just a second due to some technical errors. Yeah. So I wanted to tell that these are the risks, how you have to place and clasp assemblies, grasp the associated and resist removal of process. And a circumstantial clasp includes rest, retentive arm, and reciprocal. So this you will go in direct retainer is just a completely different chapter. Clasps are called direct retainer. You have to know reciprocal and what is the retentive arm is always on the labial side. Okay, and reciprocal is on the lingual side. You should know when retentive clasp have to touch the abutment and when reciprocal. So this diagram is depicting this. So I will just tell you in A. Figure A, when incorrectly related, retentive clasp contact the abutment and begins to deform before the reciprocal element contact. Okay, so first the reciprocal element should touch. The reciprocal arm is the first to contact the abutment. Then you give the retentive because that keeps the abutment in place. So this is a very important part which most of the place it is not told. This is very important. If you can screenshot it, better do it. A is wrong, B is right. First, the reciprocal should contact. Okay, so it is like first the reciprocal is contacting and then the retentive. Yes. Okay. So when correctly related, retentive clasp will contact the tooth simultaneously. The reciprocal element maintains contact with the abutment until removable partial denture is completely seated. Okay, so it is not that reciprocal is not the part means I'm saying they have to go simultaneously, not that one part is reciprocal is fully there, retentive is in the air. No, it's not like that. Okay, simultaneously. First reciprocal, then retentive, then reciprocal. See how beautifully it is given in the diagram. A is wrong. Okay, here what is happening? Retentive fully placed, reciprocal has just touched. So it should not be like that. It should go if this, then this. Okay. And the final also both should go to simultaneous. The reciprocal element maintains contact until the removable partial denture is seated. When this relationship exists, ideal design positions the retentive clasp in the gingival third and the reciprocal element at the junction of middle and apical third of the tooth. Now, class position, this is very important. If it is class 3, means tooth supported, you're always giving a quadrilateral configuration. Okay, that is the first one which my is showing the arrow. Tripod in class 2, where I'm showing the arrow tripod. So, and class 1 bilateral. This is very important. If you know this, you know everything. Quadrilateral class 3, then you design. First you think class 3, quadrilateral class 2, and class 1, you go for tripod and bilateral. So basically, parts have told major connector, minor connector, rest seats, but how my basic PPT and my basic presentation on what are the parts, why classification is important. So as I told, how rest has to be placed. So you read direct retainer properly and get to know first reciprocal arm or retentive arm will be placed. So that is totally different topic. But from my point of view, biomechanics is very important. You should know the class position. If it is class 3, you go for quadrilateral. So if it is quadrilateral, that means where you are going. Okay, so suppose you have a class 2. So you imagine what is class 2. So if premolar is the abutment, where the rest would be placed, whether mesially or distally, why we place in distal, why we place in mesial, those are very important. So this is how biomechanic works totally on the fulcrum line. Or keeping all that in mind, you have to do a very beautiful designing. If you know where the major connector will be placed, where the minor connector will be placed, where the bone is there, I told you first you have to see everything. Plan, design, create. Plan is through, X-rays, the cast, you plan, you do this. In designing, you mark, you do the color coding, and then you execute it. So it will be wonderful. If you're making any mistakes in the cast, if you're sharing it with the other practitioners, you'll get more input, and finally you'll come up with wonderful RPD design. So this is all about the classification, biomechanics of RPD, and the other chapters which has to be dealt separately. So a partial denture which is properly designed and meticulously constructed dignifies. It's not in RPD generally, I'm telling you, people take it, for so much this, that, oh, it's RPD, it's very easy. It is the toughest. I will tell you, it is the toughest and one of the poorly designed. I've seen students, I'm a assistant professor in one of the colleges, and I've seen that, students are just making impression with cold cure anything, they're just sticking the teeth. It's not like that. Please plan, create, design. Okay, for this you should know what is the classification. You should know in detail about major minor connector. Direct retainer is the most important. You know which arm touching when, how it should go properly. If you do, they'll be wonderful. There'll be wonderful RPD. And if the patient, can pay better, we should always say CPD, that is just the metal framework, but designing is almost similar. So you should plan that, okay, rest we should give it distal or mesial, how much of the surface will be covered, then you'll do well. So if a question is coming on RPD classification, you have to write, you have to define, make the classification. If it is coming on biomechanics, you have to first mention what are the parts of RPD, then you have to write little about liver principle, fulcrum line. Then this I've shown how designing is done, when which comes first. So this all you have to mention in your answers if you're giving BDS final year exam. NEET MDS, every point is important. So despite the fact that there are numerous superb materials, techniques, many different possible design, nothing can supersede good judgment coupled with the knowledge of basic principles. Many prosthodontists use snap judgment, so they send restorations to a remotely located dental laboratory, which makes up a run of the mind appliance based solely on mechanics. The results are devastating to the teeth, soft tissues, and osseous structures. So that's why I'm telling why, what we are doing that is important. You have to design properly, you have to make properly, then only it works wonders. Okay, so for RPD, keep a cool mind, make proper impression, articulate, and then design. So thank you everyone for listening. I hope everyone follows this. Any doubts, anything, you can mail me. I've shared it with the Cynodent, and I would like to thank Team Cynodent for giving me this opportunity, so that I could share my knowledge with so many of you. Thank you once again.